now I have the pleasure to call Professor M Hussain. Everybody knows her. She's a renowned expert in geo-oncology. She's a medical oncologist, and she will talk about the treatment of metastatic castration-resistant prostate cancer in 2026. So the floor is yours.
Thank you. From the A to Z. So basically, as was mentioned earlier, when I entered the field, early 1990s, the median survival for men with metastatic castration-resistant prostate cancer was 9 months. That was the median survival. It was pretty much a deadly disease. And at that time, there were all kinds of trials done to try to test potential agents, and sadly, nothing was working. And the only first drug that got kind of approved in the US by the FDA, mitoxantrone, some of you might have not even heard of it, but that was based on like a sort of quality of life type thing and things like that, but not in terms of prolonging survival. So there was a lot of research that was going on, literally starting from the 70s, as you see here. Again, my pointer is acting up here, sorry. Can I have you put it on full screen for me, please? Just so I can just point to things. So basically, research to try to investigate the mechanisms of progression. No, full screen so I can use the pointer. Well, I mean, is the pointer going to work? Yeah, that's much better. Thank you. So as you can see here, from literally the 70s, where, this is like over 50 years ago, where research to better understand mechanisms of progression from hormone-sensitive to castration-resistant disease was going on. And all kinds of findings were identified. And I would actually refer you to these references because they're really fascinating. And it just shows up that a lot of investigation had been done. But primarily, there is a whole thing with molecular, there's clonal selection. So essentially, no two cells in the cancer are alike. And so when you kill the cancer cells that are sensitive to the hormone treatment, there are cells that are not responsive generally. So you're kind of clonally selecting them. And the other part would be molecular adaptation through different pathways and alterations in survival pathways and so on. And so the first actual drug that had demonstrated overall survival advantage in prostate cancer was Taxotere. And this was really a fascinating thing because when, I don't know how many of you might have come to ASCO plenary session in 2004, but these were like back-to-back plenary presentations at ASCO, which was really amazing because this is the first time that major overall survival advantage was noted with docetaxel with 2 clinical trials. One was an international study, one was a SWOG-led clinical trial, and it was really phenomenal. And I was part of the team that actually designed the study, but it was really huge advantage. Based on all the research that was done to investigate different mechanisms of progression to metastatic disease, mechanisms of progression to castration-resistant disease, a variety of pathways were identified, as you can see all over here. And these pathways, based on preclinical data and potential translational data, were very important. But as you can see, not every drug targeting these pathways necessarily works. So I have here in turquoise blue the different drugs that have actually demonstrated clinical benefit, overall survival or progression-free survival benefit that led to, at least in the US, FDA approval. Having said that, there are drugs within a similar class that might have not really worked. So no two drugs are alike, and I think that's why it's very critical to do prospective evaluation and not to assume just because the drug targets a pathway, it's necessarily going to work. So this is where we are in 2026. We started in essentially 2004 with docetaxel. We have really moved quite a bit with regard to treatments for metastatic castration-resistant prostate cancer. And we have actually entered the era of precision medicine. with the PARP inhibitors and the PSMA treatment, and now combination therapies. When it comes to immune therapy, I don't know if you have Spilucil T approved here, but this was the first immune therapy type thing that was approved by the FDA, which hardly is used at all, just because I don't think it really as effective as was supposedly published. And when it comes to immune therapy, Pembro, at least for us, is approved. I don't know if you have other pathways, immune treatments that are approved, but this is approved in patients who have, immune type alteration, skeletal-related events with zoledronic acid and denosumab. And this is sort of a summary of the clinical consideration for the treatment choice in these patients. There's multiple factors that you can look into, and we can certainly discuss them as to what you should go into. And critical to all this would be basically a shared decision with the patient. Now, when it comes to personalized medicine and precision medicine, essentially, I'm not going to go over all this. Basically, precision medicine uses the genetics of the disease to identify effective treatments. There is phenotypic precision, which is really where we entered into the era of phenotypic biomarkers, as in the PSMA. And so now we have actually treatments focusing on PSMA-targeted treatment. This was mentioned earlier. This is a part of the Stand Up to Cancer. And again, I had the privilege of being part of the University of Michigan team at the time. And this was essentially fresh tumor biopsies that were done from patients with metastatic castration-resistant prostate cancer. And they underwent genomic testing, and we had germline testing. And the fascinating thing was more than 20% of the patients' tumors had DNA repair pathway aberrations. 8 to 10% they had pathogenic germline. Part of the part of the project was actually the TOPARP-A study, which was investigating olaparib in the setting of castration-resistant disease. And those patients underwent testing. And what was interesting is this: there was like a 40-some patient cohort. 14 of the 16 patients who were biomarker positive, and that responded. So that shows how that fueled actually the design of the PROfound trial. Those who were biomarker negative, there was very low response rate. So the PROfound trial was a phase 3 trial. When we reported the results, first was the progression-free survival, and then we reported the overall survival. And when we designed the study, we actually sort of had two cohorts for a reason, because there was not really a lot of data on the non-BRCA ATM type cohort. And so the patients were assigned, if they were BRCA1, 2, or ATM, they were the primary cohort. The secondary cohort was anybody that had other alterations. And what you see here is basically the overall survival, and the for the primary cohort was significant. And because we wanted to allow patients to get access to the drug, those who were randomized to the AR inhibitor by physician choice were allowed to cross or if they had the HRR mutation. And so when you adjust for it, you still see a benefit in there, and this is cohort B. The one thing I would say, the primary cohort had the higher odds of response. That doesn't mean you cannot consider it in patients who didn't have the BRCA or ATM. Now, one of the issues which was driven by, again, observations in the clinic is that not everybody responded as good as, like just because they have the HRR gene, they did not necessarily respond as well. So we did actually a gene-by-gene analysis of both the progression-free survival, and I'm showing you here the overall survival. And what you see here, the BRCA2 is the king of responses. Again, not everybody with BRCA2 necessarily would respond. And the rest of them here, fascinating, ATM, you can see also a good odd of response, but sometimes is a struggle in the clinic when we're seeing patients with ATM. Now, other sort of precision treatment type approaches is the lutetium PSMA 617. And this is a radioligand, and this basically was tested in pretty much end-stage, generally prostate cancer patients who had seen prior chemotherapy and so on. And the primary trial evaluated progression-free survival, and the secondary endpoint was different time to symptomatic skeletal event and other things. And what you see here is basically that compared to the control arm, which was physician choice type AR inhibitor, demonstrated definitely Pluvicto, which is what we call in the US right now, but it is resulting in overall survival advantage. Now, one of the basic principles in oncology is essentially a multi-targeted type strategies. And so this is sort of the background, again, to give you a piece of the history as to how we got into the combination treatment of AR inhibitor and other agents, including PARP inhibitor, was the fact that preclinical data suggested, again, that clearly PARP1 had a critical role. And then AR-mediated prostate cancer cellular proliferation happens, interacts, there's PARP1 and AR signaling cascade interaction, and that castration-resistant tumors exhibit increased PARP1 activity. And based on preclinical data suggesting that the combination of an AR-targeted agent and a PARP inhibitor seemed to work better. That plus other sort of early phase type trials, and I know this was already presented a moment ago, there were 3 randomized phase 3 clinical trials. The design of these trials was a little bit different. For the sake of time, I'm not going to go through each one of them, but PROPEL basically evaluated olaparib and abi versus placebo and abi. Magnitude evaluated niraparib and abi versus niraparib, and then the TALAPRO trial evaluated the combination of enza and tala versus enza. And essentially, the results from these trials are summarized in here. But the bottom line is there were responses, and the primary responses we're seeing the most in patients who had the HRR mutation. That led to actually the FDA and the EMA approvals. For us in the US, for PROPEL and Magnitude, the approval are strictly in BRCA1 and BRCA2. The talazoparib and enzalutamide were actually approved in the whole panel that was tested in the trial. One of the questions that I think are critical is the fact that, do you really have to give combination drugs? And if patients have HRR mutation, how well is a PARP inhibitor going to cause response versus an AR-targeted treatment? And can sequential therapy work better instead of giving the patients everything all at one time versus not? So that really was the rationale behind the BRCA trial. And this is it's basically a randomized phase 2 clinical trial where we compared abiraterone, olaparib or abiraterone plus olaparib in first-line metastatic castration-resistant prostate cancer that had DNA repair defects, which is how the name came up with regard to BRCA. Now, the one thing I should point out is that this trial, actually, when we designed it, believe it or not, it was 2016, and we had like 15 institutions participating, and it was actually even before we reported the PROfound data. It just shows how much when you're doing investigator-initiated trials, it can take forever to actually get these trials going. But the bottom line, the whole idea was to try to see, again, as I mentioned, are we better off with combination versus sequential treatment? And so we reported the overall survival data. We've published the PFS data previously, but the OS is what I just presented at ASCO GU. And this is basically the design of the study where essentially patients were pre-selected for HRR mutations. Those who had BRCA1, 2, or ATM, they were randomized 1 to 1 to 1. And those who were randomized to the single agents, they could actually cross over at progression. Arm 4 was actually any patients who did not have BRCA1, 2, or ATM. Now, one thing I want to highlight here is that what was fascinating is for arm 3, which is the combo arm, had actually the highest rate of visceral metastases, liver quite a bit actually. Somehow they end up in there. And then the other thing is BRCA2 is essentially the most present HRR mutation in this particular group. What you see here basically is the objective response and PSA response. And these are the response rates. And what you see here is the combination arm had the highest rate of objective response, had the highest rate of PSA response. And you can see the depth of the PA response in here. And this is essentially what you can look at the PFS here, and fascinating, these patients actually on the combination arm literally had progression-free survival of over 3 years median, which is remarkable considering these patients had castration-resistant prostate cancer. And this is the overall survival, which is what we reported at ASCO this year. And fascinating again, I have many patients on this arm that happen to be there, BRCA2. Just example, generally younger men in their 40s when they were diagnosed with prostate cancer, progressed literally, I say in 5 minutes, but not 5 minutes, but like within a year or two with metastatic disease, then progressed to castration-resistant disease within a very short period of time, happened to have BRCA2 alteration, end up being included in this trial, and many of them were actually several years in remission, which is really remarkable when you think about it that way. Arm 4 was any patients that were not BRCA1, 2, or ATM. As you can see here, yes, there are responders, and you see the data overall on the PFS, but it's not the same magnitude as you would see in patients with the BRCA1 and 2. Now, having said that, that doesn't mean you shouldn't be considering it, but as you're really evaluating patients, and if you have this kind of alteration, but you're worried about disease progression or they have a lot of disease and things like that, you may want to opt for something, maybe chemotherapy or Pluvicto or something like that, as opposed to the PARP inhibitor. Now, one of the, again, basic principles in oncology is working on combination strategies. And this was data that was actually presented by Rena McKay at ASCO this past year, looking at the combination of olaparib plus radium. And if you think about it, this is essentially creating DNA damage and then adding a PARP inhibitor to prevent repair. So this was a biomarker-based clinical trial. And what you see here, they were stratified by the biomarker, but all patients were allowed to enter. And what was fascinating is you see that the combination of olaparib and radium did better than radium alone, with really significant improvement, almost doubling in the median progression-free survival. What was, I think, is interesting is those patients who were HRR positive or DDR positive did not have that much benefit compared to the patients who were not, which is really an interesting thing. And I think this is something that would need to be evaluated further. Now, I'm going to run through this, and these slides should be available to you to look at them or to have them. But the bottom line is there are really a lot of trials going on right now looking at PARP inhibitor combination. Clearly, immune therapy is one area where there's a lot of interest right now, and you can see these trials in there. Same thing with other pathways, and most of these trials are phase 1 or phase 1/2 type trials. So I do think it's going to be interesting to see the outcomes and what would translate into moving forward with a phase 3 trial. I'm going to run through this because it was presented just before me, but this is the society guidelines. I would say one thing I want to highlight here. When you do germline testing is not going to change. So if somebody had high-risk disease and you know, somehow they got radiation and hormones or whatever, or they have a strong family history and you decided to do a germline testing, you have that from the old days, is fine, assuming there is similar panel. If there is evolution in terms of the quality of these tests and the sort of sensitivity of it. So depending on what it is you're going to be doing, if there's a new panel, I would go with the new panel, especially if the old panel was negative from that perspective. When it comes to metastatic disease, just because you have archival tissue, and this is what we looked at again in the PROfound trial, but just because you have archival tissue, if it's negative, I would jump in and do ctDNA and even consider a biopsy if you don't have access to ctDNA, because for somatic stuff, it's evolution of the cancer. So it could have been negative, but it could have become positive as the disease progressed in that regard. Now, one thing I also point out is this: I usually use when we do the germline testing specifically for patients who are with de novo metastatic disease or progressed to castration-resistant disease, or they're young and presenting with really local regionally advanced disease and such. I always counsel the patients that the rate of germline testing results based on what we have is not exactly very high, and so the fact that a patient has, say, bad history or a family history, and the fact that their germline testing is negative does not mean they do not have the risk. And I usually talk to them to kind of counsel their siblings, their kids, depending on age, of course, for males and females to go through early detection. So, mammograms for the women and sort of PSA testing and things like that for the males in the family. So this is the NCCN guidelines, and basically this whole thing is similar to the sort of the very much the ASCO guidelines. So I want to go now as to how we are moving different treatments from sort of end-stage disease into the earlier phases of the disease. So the PSMA4, which maybe I'm sure you have seen the data from the presentation at ESMO from 3 years ago. But the PSMA4 essentially moved the Pluvicto treatment or lutetium PSMA from pretty much end-stage disease to sort of earlier metastatic castration-resistant disease. And the design of the trial was basically lutetium PSMA versus AR pathway inhibitor, and the outcomes were reported where essentially progression-free survival showed significant improvement with lutetium PSMA given, again, in the earlier phases of castration-resistant disease. What was interesting is this. Right after this was reported, for us in the U.S., the FDA approved it for patients in the sort of earlier phases, castration-resistant disease. Fascinating that the overall survival assessment did not show an improvement. Now, my guess is part of it is because we have so many different treatments available for patients that if these patients had access to these different life-prolonging therapies, it's quite possible that that may be part of the reason, which adds a question for future trials in terms of balancing OS as opposed to PFS. Now, other combinations with the radiopharmaceutical type agents is the data that was also presented at ESMO 24 by adding enzalutamide to radium. And basically, this is the PEACE-3 trial from the EORTC. And the data was reported with the interim analysis basically showing the primary analysis of radiographic progression-free survival showing clear benefit in the combination as opposed to giving enzalutamide alone. And again, this is sort of second, third line type situation, castration-resistant disease. And then the data was reported on the overall survival, on the progression-free survival by Dr. Tombal in last year at Annals of Oncology. The interesting is the interim analysis of the overall survival. I think it looks very interesting, and it's quite possible, significant improvement in the median there. So I think there is possibility that overall survival will definitely translate into a real benefit. Now, there are other pathways that are with targeted agents, and I'm going to put them in here. A lot of these things are undergoing evaluation in there. This MYC inhibitor is actually one of the projects we have in our prostate cancer SPORE, and it's very interesting preclinical data that we have on this thing. So we're hoping to have a phase 1 clinical trial started soon. Actinium is another radio ligand type therapy, which I think is having very promising early signal. And there's other pathways that are being looked at. This is the one from the Dr. Rathkoff, which she presented at ESMO and published in the Annals of Oncology, looking at a dual androgen receptor ligand directed as degrader and antagonist. So basically to try to hammer the androgen receptor. And this is based on the early phase trial, which showed really interesting responses and progression-free survival. And what you see here, the patients who had no prior chemotherapy versus prior chemotherapy, you can imagine the sicker the patients or the more heavily pretreated patients, the odds of response is lower. However, I do think it's very promising, and this agent is going to be moving into additional testing. So to end with this, we've really come a long way in managing metastatic castration-resistant prostate cancer. If you look at it from the 40s until 2004, technically we had no life-prolonging treatments for these patients. And since 2004, with docetaxel showing survival improvement, we've seen loads of different agents. And again, this is focusing strictly on castration-resistant disease. I'm not adding the approvals for hormone-sensitive disease. And we've entered the era of precision medicine and so on. So if we've really come a long way, the reality of it right now, the cancer continues to be a very complicated cancer. So this is from an autopsy series, which is really fascinating. Each one of these columns is one patient. And essentially, if you analyze the tissue from different parts of the body of that patient, you can see the complexity of the different genomic alterations that you see in there, which tells you prostate cancer is a very sneaky kind of cancer. I don't want to call it smart. It's very sneaky, and it evolves over time. And this is very critical, I would say, to pay attention to early signals of progression so that one can hopefully intervene and prolong life. So this is the summary here. Clearly, there's been significant progress. When it comes to actually, and I'll be speaking about hormone sensitive tomorrow, but basically, as I said, when I was entering the field, the median survival for hormone sensitive was 2.5 years, and now it's 5+ years, actually 6, in fact, I think. And we have many patients literally 10 years alive and in remission. And then castration-resistant disease was 9 months, and now it's 3+ years. I'm sorry. So there's really a lot of improvement. Clearly, multi-targeted therapy improved outcomes in both disease setting. We've entered the era of precision and personalized medicine. I showed you the different trials that were there. One thing I would say, prostate cancer is very complex, and it tends to be a smart cancer with a lot of inter and intra-patient heterogeneity. And clearly, anything that we're going to develop in the future has to kind of focus on the totality of the disease biology with comprehensive molecular understanding of the disease states, mechanisms of resistance and progression. Multi-targeted approaches are critical. Clearly, what we're seeing right now, a lot of the drugs are moving into the earlier phases of the disease. So Taxotere was end-stage disease. Now it's frontline hormone sensitive. All of the AR inhibitors, much more powerful than what we had before, have moved into the earlier and earlier phases of the disease. And the question comes up is the biology of the cancers that we're going to be seeing the same as it used to be and what we did, the stand up to cancer work and things like that? Clearly, I think we need to be much more working on this project, and I would say clearly well-designed trials are needed to address the different questions. And with that, I want to thank you, and I will stop.
Wait, thank you for your relevant communication. We move to question. Karima, can you come here? For audience, you have a question? Yes, yes.
Okay, I'll stay. Thanks.
Karima.
Okay, Karima, come on up. Is this just a girls' session?
For men cancer. Thank you for the two excellent presentations. As a urologist, I would like to know if we still need genetic testing, if we have a result, very good result with the combination RP-PARP. Without, we have seen that the cohorts are the same as a result. Do you need still germline?
Or somatic
Thank
testing.
You.
I think for those of us in the US, we have to do it because the actual FDA approval is strictly in the combination arm in the setting of HRR mutations. Now, one of the difficulties is sort of balancing risk and benefit. And I think that I would do it anyway just for the heck of it because then there may be other agents that might be coming at second line, third line that might be targeting the PARP pathway kind of thing. That might give you a chance to offer to the patient.
For the same subject in Morocco, we have the approval regardless of
Regardless,
HRR.
which is
But
like
in
the
Europe.
EMA, because we follow more the EMA.
No,
But
but
in
do you
our-
think that there is a certain amount of benefit in this subpopulation? Do you recommend, I know that in US it's restricted to HRR according to Talapro study and BRCA2 according to magnitude and Propel, but do you think that in some patients we can prescribe the combination without mutation? What do you think?
So I would say you'd have to go with your gut feeling. If you think you have some wiggle room, like there's not an acute progression of the patient, there is potential time, it's just the PSA is up and the scans are, you can try it if you have it approved, no question about it. The one thing to be clear about is, so all of these were done in settings of kind of frontline castration resistant, where a lot of the patients had not seen those potent AR inhibitors in the hormone sensitive space. Nowadays, and this is part of, I think, why the FDA might have not approved it, but for us, we've had Enza, APA, Daro, AbbVie approved for many years now, and in the hormone sensitive. And so the difficulty is it going to apply or not? So you kind of have to go with your gut feeling. But I would say anytime you think that you have room and that you're not going to cause worsening of disease in a rapid way, you can try it.
Professor Walla?
But I'm sorry, but I would counsel the patient just to make sure that they are, clear.
There is no doubt that genomic testing has shifted the management of prostate cancer from one size fits all to more tailored and personalized approach. My question is about the real challenge of integration of these tools into the Moroccan clinical practice, taking into consideration the high price of genomic testing, the high price of PARPI, and also the lack of big data regarding the genomic council of Moroccan population. And we have to congratulate the effort made in genomic testing to Moroccan population with breast cancer, lung cancer, colon cancer, and we hope that will be extended to prostate cancer as well.
Yeah, I think it's a matter of time because, as he mentioned, for breast and lung cancer, yeah, now things are more clearer in Morocco about the prevalence, for example, of AGFR. We have our own data, and so for breast cancer population, like for the biomarkers that are in practice used. So we have more specific data for Moroccan population. But you are totally, I agree with you totally because we have lack of data in terms of testing, specifically in prostate cancer, and in the studies that when I did a search on the web, and I found prostate cancer with breast cancer and ovarian cancer. So the BRCA alterations were found in a pool of patients with different disease, which is a good first step. But we need really urgently to have our own data registries, and also since the drugs are there, the approvals are there, and when a drug is available and it's guided by the biomarker, it's just not smart to have, available ways and feasible ways of testing in public hospitals. So we do have in many hospitals in Morocco, like in Rabat, so we send patients in Casablanca also. And of course, there is a partnership also with private sector. We should recognize that we have also the support from pharma to get the testing, because it will help so the prescription of the drugs. But many things are still to be done, sure.
So I would say this would be a great project, because the reality of it, we assume that all humans have the similar genes. Well, yeah, we are all from Adam and Eve, but we evolved over time. And different regions have different sort of genomic profile. And I have to say, in my practice, as you can imagine, I see all kinds of background men with different race and ethnicities and all of that. Surprising to me, and again, this is sort of anecdote, the majority that have the HRR mutations are white men and white European men. We have a bunch of Middle Eastern people. We see a lot of black patients, but for whatever reason, and again, this is more of an anecdote from my experience. So I do think, the evolution of the races is different, and this would be, I think, a nice thing to actually partner perhaps with Foundation, with any of the other Tempest or somebody to do a project just to kind of maybe North Africa type thing or even Morocco type project would be great actually. Yeah. But I would say I would do also the germline testing, and this is where you could do, guys and girls, men and women, based on breast, ovarian, all of that, just to get a feel for that.
As you have noted that for metastatic prostate cancer, resistance 20% have BRCA2. My question for the others, other prostate cancer that have aggressive evolution, but we don't find genetic mutation. My question, is this something that we ignore? Other genetic mutation that science maybe haven't discovered? This is the question for you. Is there any research, to look for others, mutation maybe that we ignore, and they may impact the treatment and the precision treatment for our patients?
So this is really, to me, where the scientists, we need their help. Because again, all the panels we have are based on what we know today in terms of genomic testing and things like that. The other part, these were done at a time where we didn't have all the different treatments that we were using. So the question comes up right now, is the biology, the molecular profile of a frontline castration-resistant disease the same as when we did the Stand Up to Cancer project? My gut feeling is probably different, just because since then, Taxotere became part of it, AR inhibitors became, and I'm saying all of these things kind of became part of it. So that's where I think more research is needed. And these are actually great questions and potential opportunities, perhaps partnering again with private entities, because again, one of the advantages you have is that this is Africa. It may have different profile of the genes compared to, say, what Europe is or US is or something like that. And I do think sort of easy, start with a pilot project type thing, maybe just do, an early project and then work on expansion based on that.
In the same sense, as you know, in the prostatic resistant cancer, you have a high level pattern of neuroendocrine.
Yes.
How this data can change our practice in 2026?
Well, this is fascinating. You must have read my mind because we're working on a paper right now. So I just want to clarify a few things, or a couple of things. So the neuroendocrine features are sort of being implicated as an aggressive variant, of the prostate cancer. But I would like you to distinguish generic neuroendocrine from small cell. Because you can have with prostate cancer, and again, I'm not a pathologist. If there are pathologists, they can chime in. But basically, an adeno with neuroendocrine differentiation is one thing. But an adeno with small cell variant is totally different. It is neuroendocrine, but it's small cell, which is nasty. And actually, what I have began noticing, which I put a panel of US people and from the Royal Marsden, UK, a project to look, we presented poster data at ASCO GU, because for whatever reason, I began seeing more patients who present with whatever prostate cancer, then either de novo metastatic or progress to metastatic disease after locoregional treatment, and then they are responding to hormone treatment, and I usually do scans periodically, and I kind of tailor them depending on how long a patient has been out of, has been on treatment. And surprisingly, I'm beginning to notice that there is metastatic disease, liver or lung, and yet the PSA is undetectable. And then sometimes I'm old-fashioned, I'll go and check acid phosphatase, is it up? And no, it's not. So we biopsy the tumor, and guess what? It's small cell. So not endocrine, it is in neuroendocrine technically, but it's a small cell variant. And the question is why? And I'm happy to share our poster if you're interested. We had like over 100 cases from a bunch of places, again, in the US and the UK. So right now we're working on the paper, but I do feel like this is an area where it needs definite research because it's really not clear why this cancer is moving into the small cell, differentiation, which is scary actually.
So I have one question for Professor Walla and the other one for Professor Mao. So I will go back to active surveillance as a urologist. How could the genetic testing impact our behavior and best risk stratify this subgroup of population in order to push out some patients from active surveillance and to save
active
some,
treatment?
Yeah, to active treatment.
Yeah, I think it was mentioned by
Yeah.
by Professor by Professor Said Moudouni when he presented the active surveillance, that the molecular or the genomic features, will inform us about the the aggressivity of the disease, and so in general. So we base your decision, so the urologist, to go for active surveillance or active treatment based on the classical features, which are the TNM, which are the grade, which are the etc. So the PSA, the cores that are positive, etc., etc. But we don't know a lot about the biology of the tumor, so we're taking our decision based on what we know, the classic features. For sure, by testing patients, we will identify those subset of patients who are with high local or local regional disease, that's sure. But how it will impact now, so if I will not choose, so I think it will be to be discussed in MDT, and to see if this patient with a highly, genomic aggressive disease doesn't need to be in active surveillance, or maybe to push me more to go for an active treatment. It's my impression, but I would love to know what Professor M Hussain think about.
Yeah, because by Monday morning, my patient.
Do you
how
ask
could
for testing for localized disease? I hope so.
for my patient who are actively surveilled, so by Monday morning, what should I do?
We are struggling already with having testing
For testing.
disease where it's targetable. So
Imagine we have all
imagine
the tests. Imagine we have all the tests. Yeah.
I want just to add, all the biomarker, you can agree with me, are modeling to detect the aggressive one. We don't have a biological biomarker to detect the indolent one.
Yeah.
So this is a huge problem because we don't know those who are negative in testing, genomic testing or somatic testing, why some of these patients will do worse
than others
after.
Well, that's because, again, what we have, none of our testing is the absolute perfection. And it is based on the knowledge we have today. So to me, ultimately, you have to go by not what AI tells you to do, but you go by what your gut feeling tells you to do for the patient. Because ultimately, the goal is cure. And when the patient presents with bad disease, you got to really treat it with the intent of cure. So just because they come up with a big clunky prostate, but they happen to be BRCA negative, who cares? Get that prostate out or take care of it with radiation. I know because Mac might tell me I shouldn't not mention radiation, but just so that, Mac, you know, I am married to a radiation oncologist, just to be clear. But I am one of those people that feel just because on what I've seen, the prostate is not worth preserving. Get it out.
So my last question for Professor Maha, if you, does it happen in your practice to have conflicting results between tissue-based biopsy, BRCA result, and circulating tumor? Conflicting results, one negative or the other positive or something like that.
Like, you mean the type of tissue?
Yeah.
The positivity?
ctDNA.
Oh, ctDNA?
Yeah,
Okay,
ctDNA
yeah.
and tissue biopsy.
So,
and how do you manage those situations?
Right, so I don't order them the two together. What I do is order, if we have tissue, I order the tissue first. And obviously, if a patient has germline already, because like, let's say a lot of the patients come see me have like really nasty disease, and so I tend to do it earlier, because the tissue, one thing about the tissue part is the older it is, the quality goes down. So for patients, let's say, who present, let's say, de novo, locoregionally aggressive disease or metastatic disease, I will actually send the tissue for both germline and somatic testing. If the germline negative, somatic negative, and now the patient progressed, I actually check ctDNA.
Okay.
Yeah.
Okay.
For all the patients or some patients?
No, the patients, the ones who where we are, who are negative with whatever we have for them, and if this is going to give them an option for treatment, yes, we have to check it. Yeah.
So-
And the turnaround time for us runs about 3 to 4 weeks, roughly.
For the metastasis side,
Yeah.
is there a difference between local tumor and metastasis side? Does it happen to have any profile different?
There is.
Yeah.
The analysis showed that there is high concordance, but as it was said, yeah, it depends on the delay, if it's a recurrence between the primary and the new met when it appears, and it depends also on the site, as we mentioned. So no, it's not bone, it's not, so it may alter, it may impact the quality of the testing. Yeah, yeah. So that's where the interval play a role. So it's not a question, but I just want to share this with Professor Maha. That so.
Maha, that's it. Guess what Trump uses Maha for? They have now the Kennedy dude is doing this, is they are calling him Maha, and suddenly one of my patients comes in, he says, Dr. Hussain, they're using your name, Maha. I'm like, what are they saying? They're saying, make America healthy again.
Oh, yeah. So yeah, you have mentioned that when you designed the trial for the combination RP plus PARP, etc. So yeah, the previous lines were different from now. When they asked the question about the first line combo, and this is a problem for us here in Morocco, because it's a problem because first of all we have this approval regardless of the biomarker. It's good and not good in the meantime, and also we have most of our patients, and I think we can all agree on that all our patients received RP, so it's a really minority that received docetaxel alone. So if it's not a triplet, it's so if for me, if the patient received already the RP and is not mutated, this is the bad candidate for the combination. This is my gut feeling. So I don't know what you think about this. So do you agree with me to, I don't know, to not prioritize those
So I fully agree with you, because I do feel like if we're getting into the era of personalizing care, you really want to give it to people as opposed to one size fit all. Give it to people who you think have a better chance. Having said that, if you think there is no safety concern and no imminent danger from like the cancer itself, then you can give it a try. It doesn't hurt. And then see how the patient respond. The difficulty, of course, is you don't know, are they responding to the doublet or are they just responding to one of the two drugs? And again, I would say the odds are, I feel like we're much more into the personalized care, and part of the issue that I have concerns about, just because the assays that were used in some of these trials did not detect, the HRR mutation, it doesn't mean there wasn't anything there. So it's sort of the devil is in the details, yeah.
Could I add one? Yeah, I have enjoyed the discussion tremendously. I have 2 comments and 1 question. I'll give you the question first. It has to deal with the impact of age and the addition of abiraterone. I think, I've looked at some of the data, and in older patients, I tend to avoid it, but I want to hear your thoughts. There was a comment about markers that suggest indolent disease. And actually, in a sense, there are. Tomorrow I'll talk about biomarkers a bit, but when I see a patient that has a low Decipher score and they have a negative Artera, which is another assay that says they won't benefit from hormone therapy, then I add those into my equation to say, because those markers either give you a high score, an intermediate score, or a low score, and sometime when I'm trying to decide what to do, I will use that score as something to sort of break the tie and choose less aggressive disease. So I really want to hear about your thoughts on abiraterone in patients over the age of 70.
Oh, I mean, you can come to my clinic. I have men in their 90s on abiraterone. So there's all, they golf and play more than I do. I mean, you have to, again, you're going to have to kind of assess the risk and benefit part of it. And I have to say, abiraterone, unless you have issues with like the steroid part or the heart failure part, or things like, or cardiovascular or kidney function or something, I have to say, you can get away with it okay. I tend to kind of worry about ENZA in the older patients. Even when you look at the ENZA-TALA, it's pretty powerful data and very great. The difficulty in older men, I worry about the issues of, risk of, strokes and falls and stuff like that. But again, when a guy comes in and he walks 10 miles a day and all of that stuff, and they're fit enough, it's one of those things. I usually get them through cardiac evaluation just to make sure I'm not missing something, and consider using it.
See, I'm not convinced it's not a biology difference as opposed to healthiness issue. In the initial STAMPEDE study that randomized patients with hormones and radiation, plus or minus abiraterone, when you look at the forest plot, there's a huge benefit in men under the age of 70, but no overall survival benefit in the people that are 70 or older. And there was a presentation at ASCO GU in San Francisco, I don't remember if it was this year or last year, where there was a study that looked at the impact of age.
Right.
And there was a suggestion that there was less of a benefit. I'm not sure that it's healthiness. I think the biology in older men is different than the biology of prostate cancer in younger men. So that's sort of my concern.
But I think part of it is this. A lot of these data is kind of retrospective. So when it's retrospective, you never really know what kind of other nuances there might have been that could have been causing this part. So it's, again, balancing risks and benefits and deciding. Anytime, as I said, you think you're going to cause harm, you don't give it. But I would say when you look at the combination data versus, the single agent data, there's no question the combo in the front line, remembering that all of that we had on the single agents were more like second line downstream.
It's always much more complex than we think.
I have a last question about the therapeutic sequence between lutetium PSMA is not yet available in Morocco, but I think that it will come soon. And the best therapeutic sequence, given the data of PSMA4, there was a significant benefit in the pre-docetaxel in PFS, but not in OS. So what is for you the best sequence between docetaxel and lutetium PSMA?
So I think I would favor dosi if you haven't given it as part of a triplet treatment for hormone sensitive. Partly because what I worry about, and again, this is sort of based on personal experience, not necessarily high-level data, but we published in, I think, an article in JAMA Oncology. One of the issues is with radium is that, remember, it's a radiation treatment, and we've had cases where literally the bone marrow got wiped out. And so then that prevents you from multiple other lines of not just dosi, kabazi, PARP inhibitors, the whole thing. So I would say you balance it. Where I would use it and, add an AR inhibitor to it, sort of like some of the data that's emerging is in situations where patients are older and I don't think it's safe to go with chemo, or they've seen chemo before for hormone sensitive and now they've progressed. So it's sort of, again, balancing risks and benefit. And I have to say these tend to be a very long conversation with the patients and giving them information, but taking all of that into account.
Just a last comment. What do you think about, because not always, since we have the approvals, a few years, but it's not always feasible to give PARP inhibitors so easily. We have to wait for approvals, reimbursements, etc. If I have my patient mutated and still don't have the facility to give the PARP inhibitor, what do you think of platinum plus cabazitaxel? Is it? You do that?
Yeah, do that. Yeah.
Because we do that, so just to make us comfortable.
Know the mutation. When we exhausted all the standard treatments, at the end we give carboplatin.
We talk about the genetic testing. In USA, we have less than 2% use test in prostate cancer. Why? Yes. Low.
Where?
Low. No, in USA.
Oh, in the USA?
Yes.
Well, no, I mean, again, remember, people in practice are not focusing just on prostate cancer. You have patients, large group practices where they see literally head-to-toe cancers. And so keeping track of all the nuances and the details and everything else is not there. What I actually find very interesting is that now that patients have access to all kinds of internet information, the patient goes to the doctor and say, dude, I want my tumor tested, I want my germline tested, literally. And they end up doing it. So I do think having symposia by the society for patient education, or like healthy people but potentially at risk of cancer or something like that, I think spreading the word out is important. But ultimately, if it cannot be paid for and if it cannot be, ordered, well, your hands are tied.
Thank you very much.
Thank you all. Thank you very much.
Karima, thank you. Thank you for your time.